Hello, I'm Rollins, and welcome to American Hospital and Healthcare Management. This is your gateway to the latest innovations in hospital innovations, healthcare technology, medical breakthroughs, and patient care strategies across America. Whether you're in hospital administration, clinical operations, healthcare information technology, or any corner of the healthcare ecosystem, stay informed and ahead of the curve with American Hospital and Healthcare Management. Anytime, anywhere. Want more? Subscribe now at www.americanhhm.com/subscribe and get the latest insights delivered straight to you.
Welcome, listeners. My name is Sarah, and I'm truly delighted to host today's episode of the American Hospital and Healthcare Management podcast. Today we're exploring a fascinating and fast-evolving area of modern cardiology, one that blends technology, precision, and patient-centered care. Dr. Khalique is a highly respected cardiologist and imaging expert, recognized for his leadership in advancing multimodality cardiovascular imaging. His work has been instrumental in shaping how imaging programs integrate multiple technologies to improve diagnosis, treatment, and patient outcomes. In today's episode, we'll be discussing his insightful topic, the rapid evolution of multimodality cardiovascular imaging programmatic development. Our conversation will explore how imaging programs are evolving to combine various imaging techniques, like echocardiography, CT, MRI, and nuclear imaging, into cohesive, efficient systems that enhance clinical precision and collaboration. So, with great enthusiasm, let's welcome Dr. Omar Khalique to the show. Hi, Dr. Khalique. Thank you for joining us today. It's a real honor to have you on the podcast.
Hello, everyone, and a very warm welcome to all the listeners. I'm Dr. Omar Khalique, Director of the Division of Cardiovascular Imaging at St. Francis Hospital and Catholic Health. Hi, Sarah. It's truly a pleasure to be here with you today. Thank you for inviting me to join this wonderful platform. I've been following the American Hospital and Healthcare Management podcast, and I really appreciate how it highlights voices that are shaping the future of healthcare. What stands out to me about this platform is its ability to bridge innovation and collaboration, bringing together experts from different fields to share knowledge that can drive real-world transformation. Today, I'm very excited to discuss the title, The Rapid Evolution of Multimodality Cardiovascular Imaging Programmatic Development. This topic reflects an important movement in modern cardiology, how imaging programs are evolving to integrate multiple technologies such as echocardiography, CT, MRI, and nuclear imaging into a unified approach that enhances both precision and patient care. In this conversation, we'll explore how these imaging modalities work together to create a more comprehensive understanding of the heart, supporting accurate diagnosis, better treatment planning, and improved outcomes for patients. I also want to share how collaboration, education, and innovation play a vital role in building and sustaining successful cardiovascular imaging programs. It's not just about the technology, it's about creating a team-driven ecosystem that continuously learns and adapts. I'm really looking forward to discussing these insights and the journey behind them, and I hope this conversation offers some inspiration and practical perspectives to everyone listening today. Let's get started. A brief history and description of silos of multimodality cardiovascular imaging. As technology progressed, various CVI modalities were developed in the 20th century. These included M-mode echocardiography (ECHO) in 1953, Edler and Hertz, single photon emission computed tomography in 1963, Kuhl and Edwards, cardiac computed tomography in 1972, Hounsfield, positron emission tomography in 1973, Phelps and Hoffman, cardiac magnetic resonance in 1973, Lauterbur, and the important hybrid field of structural heart disease imaging in 2007, Hahn, Leipzig, Lyon. Due to the sequential nature of the CVI modalities that were developed at different times and in different locations with different technological factors, each progressed separately. This created 4 general categories of CVI: 1 echocardiography, 2 nuclear cardiology SPECT plus PET, 3 CMR, and 4 CCT. It was rare that a physician was an expert in more than one of these CVI modalities. The rapid evolution of the field of structural heart disease and SHDI demonstrated clearly that expertise was required in multiple CVI modalities to facilitate pre-procedural planning and intra-procedural case guidance. Multimodality imaging expertise is becoming more common for new trainees and is routine for those focused on imaging practice. Current and future growth of cardiovascular imaging. Cardiovascular imaging is one of the fastest growing areas of the healthcare market. From 2013 to 2022, United States Medicare data have shown that PET, CMR, and CCT volumes have more than doubled, tripled, and quadrupled, respectively, whereas echo volumes have slightly declined and SPECT volumes have declined by 1/3. In total, given that echo and SPECT are the highest volume modalities, a slightly decline in total CVI procedures has occurred. However, the projections for CVI moving forward estimate a compound annual growth rate of 6 to 8% moving forward, with a higher CAGR expected from CCT and PET as compared to other modalities. Cardiologist billing for the combination of CCT, CMR, and PET has decreased from 73.6% to 58.6% of the procedures from 2013 to 2022, while radiologist billing has increased from 19.7% to 35.2%. Challenges. Both cardiologists and radiologists are currently facing worsening national supply-demand mismatch within their fields. Cardiologists in training receive minimal education in the newer CVI modalities of CCT, CMR, and PET. To become proficient in these, extra training beyond the 3 years of cardiovascular diseases fellowship is usually required. In most hospitals around the United States, CCT and CMR programs are run within the Department of Radiology, which can further limit and complicate training for cardiology fellows. As CVI fellowships are not accredited by the Accreditation Council of Graduate Medical Education, CVI is not a universally recognized subspecialty of cardiology. While the American Board of Radiology certifies radiologists to read CVI studies, the training and exposure to cardiovascular anatomy, physiology, and clinical cardiovascular implications may be limited during general radiology residency. As CVI study acquisition and interpretation is more technically challenging and time-consuming than the vast majority of radiology non-CVI studies, image quality and turnaround times may suffer. Reimbursement is another challenge for CVI, as non-invasive diagnostic studies are reimbursed at a lower rate than invasive diagnostic studies and therapeutic interventions. The facility fee and read of a coronary CCT, for example, is reimbursed at a few $100s, whereas an invasive diagnostic angiography without intervention would be reimbursed approximately 10-fold higher for a similar time of assessment. Many cardiologists are also encouraged to participate in structural heart disease imaging due to the massive manpower demands of the field, and are then exposed to radiation and orthopedic risks, which are incongruous with salary. Reimbursement-based limitations in the salary of an imaging physician and occupational risks lead to lower recruitment into the field. Practice patterns in both cardiology and radiology result in limited dedicated time to read CVI studies. The above factors may further lead to job dissatisfaction. Due to the rapid growth of CVI, training, quality assurance, and throughput are major challenges. while attempts are being made to enhance training quality and increase the number of training slots to produce more cardiologist and radiologist imaging physicians, other solutions must be pursued in parallel. Artificial intelligence is prevalent within non-cardiac radiology workflows and to some degree within CVI workflows. However, the accuracy and reproducibility within cardiac workflows is more challenging given the complexity of CVI, and the field must ensure that before AI adoption in the attempt to improve efficiency, that further overburdening CVI physicians with verifying AI workflows does not occur, in which case no true increase in efficiency would be achieved. The development of new training statements is struggling to keep pace with the evolution of the field. As an example of the rapid knowledge increase in the field, a PubMed search of multimodality cardiac imaging demonstrates an increase in publications from 8 in 2004 to 1,617 in 2024, a greater than 20,000% increase in 20 years. After training is completed, continued training occurs rapidly on the job through a variety of resources. However, due to the exponential increase in information, ongoing education remains a significant challenge. Organizing cardiovascular imaging services. Traditionally, the subspecialties organized within cardiology include interventional, electrophysiology, and heart failure and transplantation. Newer models include adult congenital heart disease, overlap with pediatric cardiology, and preventive cardiology. Organization of the CVI modalities within a dedicated division of cardiovascular imaging is a preferred method of solidifying this field into a recognized subspecialty of cardiology within institutions. The CVI physicians work within the DCVI in their clinical, research, and teaching roles. In parallel, a cardiovascular imaging service line can be developed, which includes management of all of the CVI modalities across hospital and ambulatory locations within a health system. The leadership who governs the service line is responsible for overseeing and implementing strategic, financial, and quality initiatives for the CVISL. The DVCI-CVSL is a more efficient way of handling these initiatives and eliminating traditional silos within CVI. The CVSL model also facilitates incorporation of the significant technical resources necessary for the innovation-heavy CVI space. Other unique aspects of the CVSL result from the involvement of cardiologists and/or radiologists who perform clinical CVI reading services. The CVISL is integrated as part of the overall cardiovascular service line, which improves its efficiency and connection to the main service line, with center-specific governance councils, cardiology imaging physicians, non-imaging cardiologists, including but not limited to general, electrophysiologists, interventionists, and heart failure cardiologists, and dyad administrators would be important leaders. Radiologists, where applicable, could also be part of the membership of the CVSL if needed, as they are important stakeholders in reading non-cardiac findings and possibly CVI studies as well, depending on local operations. However, in newer models, where the CVISL is incorporated within the CVSL, the Governance Council mainly consists of cardiovascular specialists. Needs for the future revolve around attracting trainees to the field, balancing efficiency with quality, and optimizing reimbursement. Attracting new trainees should start in general cardiology fellowship, where current exposure is extremely limited. A significant increase in the number of training slots is needed. While newer generation trainees are attracted to the technology and non-invasive aspects of CVI, higher salaries and CVI-dedicated practice patterns will be required for retention in the field. Volumes are outpacing the rate of new hiring and resources, and thus improvements in AI to reduce the CVI workload and maintain quality will be additive. Furthermore, efforts legitimize the field as an accredited subspecialty, and advocacy work will be needed to improve salaries to reflect the significant extra training and expertise required to produce high quality and accurate results.
That was an incredibly insightful discussion, Dr. Khalique. Your perspective on how multimodality cardiovascular imaging is evolving truly captures the innovation and collaboration driving modern cardiology forward. Thank you so much, Dr. Khalique, for sharing your expertise, experience, and vision with us today. It's been a real pleasure to explore your article, The Rapid Evolution of Multimodality Cardiovascular Imaging Programmatic Development, and to understand how integrated imaging strategies are reshaping both diagnosis and patient care. What stands out most is your message about teamwork, adaptability, and the human connection behind every advancement, how great imaging programs are built not only on technology, but on shared purpose and collaboration across disciplines. I'm sure our listeners will find your insights both educational and inspiring, especially as the field continues to evolve at such a rapid pace. Once again, thank you, Dr. Khalique, for joining us on the American Hospital and Healthcare Management podcast. Your work reminds us that progress in cardiovascular care is driven by vision, dedication, and a commitment to improving patient outcomes, one innovation at a time. And to all our listeners, thank you for tuning in. Stay curious, keep exploring, and continue to be inspired by the brilliant minds advancing the world of healthcare. Until next time, this is Sarah, signing off from the American HHM platform. Take care, stay inspired, and we'll see you in the next episode.